All right, if you've got exams coming up, you've landed in exactly the right spot. Today, we're doing a high-yield deep dive on malaria. We are going to break down everything you absolutely need to know to crush any questions that come your way.
Okay, so here's the game plan. We'll kick things off with the absolute basics. Then we'll trace the parasite's sneaky life cycle, which is key. After that, we'll get into the clinical picture, what the patient looks like, and the really nasty complications. Then how to lock in the diagnosis, and we'll wrap up with treatment and prevention. Let's do this.
All right, first things first, let's build that solid foundation. I promise if you get this right, everything else just clicks into place.
So what exactly is malaria? Well, in a nutshell, it's a protozoan disease. The bad guy here is the Plasmodium parasite, and its getaway vehicle? That's the female Anopheles mosquito. And yeah, it's a fun little tidbit for your exams. The male mosquitoes are basically vegetarians. They're not the ones causing all the trouble. Okay, this table right here, you're going to want to screenshot this, tattoo it on your brain, whatever it takes. Examiners love asking about these classic fever cycles. So, tertian, that means the fever hits every 48 hours, or every third day. Quartan is every 72 hours, so every fourth day. And then you've got nolesi, the odd one out, with a daily fever. This is pure gold for your multiple choice questions, seriously.
Now, how are you going to remember all those names under pressure? Easy. We've got a mnemonic for that. Very fierce monsters often kill. Just lock that phrase in your head. Vivax, falciparum, malariae, ovale, nolesi. Bam. Easy points on exam day.
Okay, next up, the parasite's life cycle. Now, if you can wrap your head around this journey, I promise you, everything else, the symptoms, the complications, even the treatment, it's all going to make perfect sense. So it all starts with a bite, right? The mosquito injects these things called sporozoites. Think of them as little torpedoes heading straight for the liver. Once they're inside the liver cells, they go into stealth mode and multiply like crazy, turning into merozytes. Then boom, they burst out and launch an invasion on our red blood cells. This is where the real trouble starts. They multiply inside the RBCs, rupture them, and that's what causes the classic fever. Finally, a few of them change into gametocytes. Basically, the male and female forms, just waiting to get picked up by the next mosquito.
Now here's a super important concept, a favorite for tricky exam questions, hypnozoites. Just think of them as sleeper agents. With P. vivax and P. ovale, some of those sporozoites that go to the liver, they don't multiply right away. Nope. They just go to sleep. They can stay dormant for months, even years, and then, out of nowhere, they wake up and start a whole new infection. This is what we call a relapse, and remember, it's unique to vivax and ovale. And that brings us to a classic exam trap, distinguishing between relapse and recrudescence. They sound similar, but they're totally different. Relapse, like we just said, is from those sleepy hypnozoites waking up in the liver. That's vivax and ovale. Recrudescence, on the other hand, is when a few parasites survive the initial treatment in the bloodstream and then make a comeback. That's what you see with falciparum and malariae. Liver versus blood. That's the key distinction you need to remember.
Okay, we've got the life cycle down. So let's switch gears and look at the patient. What does malaria actually look like when someone walks into the clinic? And more importantly, why is falciparum the one that gives us nightmares?
So for your standard run-of-the-mill, uncomplicated malaria, you need to have this classic triad in your head. First, those spiking fevers that come and go. Second, anemia, which makes total sense, right? You're destroying a ton of red blood cells. And third, a big ol' spleen, splenomegaly, because it's working overtime trying to clean up all the mess.
And that fever spike, the febrile paroxysm, it follows this really dramatic 3-act play, and it's all timed to when the red blood cells burst open. It starts with the cold stage, the patient is freezing, shaking uncontrollably. Then comes the hot stage. The fever skyrockets, they have a pounding headache, and their skin is burning up. Finally, the sweating stage. The fever breaks, they start sweating buckets, and they feel exhausted, but for a little while relieved, until the next wave hits.
But then there's P. falciparum. This one plays a completely different and way deadlier game. And the keyword you have to remember is sequestration. What does that mean? The red blood cells infected with falciparum get all sticky. They start clinging to the inside walls of the tiny blood vessels, especially in crucial organs like the brain and kidneys. This creates tiny traffic jams, blocking blood flow, starving the tissue of oxygen, and it also lets the parasite hide from the spleen.
And I want to be absolutely clear about this. Sequestration isn't just some interesting biological detail. It is the very reason falciparum is the killer.
This process, which is driven by a protein called PFEMP1, is what leads directly to things like cerebral malaria. You have to be able to recognize what's happening here. And the results of sequestration are just devastating. Cerebral malaria, think seizures, coma, that's the one we fear the most. Then you have black water fever, a terrifying syndrome where there's so much red blood cell destruction that the patient's urine turns dark, almost black. On top of that, you can get acute kidney failure. Anemia is so severe it's life-threatening, and fluid in the lungs. This is a full-blown medical emergency.
Okay, so you've got a patient, you suspect malaria. How do you prove it? This part is crucial, loaded with high-yield info for your practicals and clinical vignettes.
The one and only, undisputed champion, the gold standard for diagnosing malaria, is the peripheral blood smear. It's beautiful in its simplicity, it's cheap, and it lets you literally see the parasite with your own eyes, figure out how many there are, and most importantly, identify exactly which species you're dealing with.
And when we do a smear, we actually make two different kinds. First is the thick smear. Think of it as a big glob of blood. We lyse the red blood cells, which concentrates any parasites that are there. This makes it super sensitive for detection. It answers the question, is there any malaria here, yes or no? Then you have the thin smear. This is a neat single layer of cells. It's not as good for finding the parasite, but because the RBCs are intact, it's perfect for speciation. It answers the next question. Okay, we have malaria, but which species is it?
And on that thin smear, there are a few dead giveaways. But for falciparum, you need to burn two things into your memory. One, multiple tiny rings inside a single red blood cell, sometimes stuck to the edge, we call those acicole forms. And two, the absolute classic, the money shot, the banana-shaped gametocyte. You see that crescent or banana shape? It's falciparum. Game over, no doubt.
Now, out in the field, you'll see a lot of rapid diagnostic tests. They work by detecting parasite antigens. The trick is just knowing what the different lines mean. There's usually a line for HRP2, which is specific to falciparum, and another line for PLDH, which is pan-malarial. It detects all the species. So think it through. If only the HRP2 line shows up, it's falciparum. If only the PLDH line is positive, it's one of the other guys. And if both lines are positive, well, that means it's either a mixed infection or it's just pure falciparum.
All right, diagnosis is in the bag. We know what we're fighting. So, how do we win? Let's talk treatment and prevention.
Okay, treatment is all about knowing your species. For vivax and ovale, you hit them with a 1-2 punch. Chloroquine for the parasites in the blood, plus primaquine to go after those sneaky hypnozoids in the liver. You have to use primaquine to prevent a relapse. For uncomplicated falciparum, it's a different story. Because of widespread resistance, the go-to is an artemisinin-based combination therapy, or ACT. And for any severe malaria, you treat it as an emergency with IV artesunate.
When it comes to prevention, it's all about one thing: controlling the mosquito, the vector. We do that by targeting the adult mosquitoes with things like insecticide-treated bed nets and spraying indoors. And we also go after the larvae, right? That means getting rid of stagnant water where they breed, or even using biological warfare like putting special fish in the water that eat the larvae.
Phew, we've covered a ton of information. So let's do a rapid-fire review and boil this all down to the absolute must-know points for your exam. This is your final cram session.
Okay, let's lock this in. Falciparum, it's the killer. Why? Sequestration. Gold standard for diagnosis, peripheral blood smear. Thick for detection, thin for speciation. What's the key look for? Falciparum, banana-shaped gametocytes, and those little accolate rings. Relapse is from the liver in vivax ovale. Recrudescence is from the blood in falciparum. And treatment? Remember to add primaquine for vivax ovale and use ACT for falciparum. If you know this slide, you are in great shape.
All right, let's finish with a quick clinical challenge to put it all together. A patient's blood smear comes back. The report says multiple ring forms and aviculio forms. Immediately, what is the single most feared complication you need to be watching for? The smear is screaming P. falciparum, and that means you have to be on high alert for cerebral malaria. That's how you connect the dots from the lab to the bedside. Great work today.